breaking barriers and bridging the gaps between patients and doctors. Welcome to Brainstorming with the Docs and your co-hosts, Dr. Glenn Harrison and Dr. Colby Condos.
All right, everyone, welcome back to this week's episode of Brainstorming with the Docs. I'm Dr. Colby Condos, my co-host, the man in the tie, Dr. Glenn Harrison. Today, we are going to be talking about something that we see very commonly in our clinics, which would be cases of musculoskeletal pain that are unresponsive to regular conservative care or pharmaceutical care. If this is your first time listening to the podcast or watching on YouTube, and you have questions about your own health, feel free to like and subscribe and turn on the notifications so that in the future, when we continue to break down these healthcare questions and conditions, that you get notified when that stuff comes online. So without further ado, how you doing, buddy? It's been a minute.
I'm doing good. I had some downtime. I know we talked a little bit about that. I'm feeling stoked for what we have in the future. I know we'll be releasing that a little bit in what we're planning. But I'm really looking forward to this podcast because we talked about some cases, which hopefully we have some time to share today, of these individuals that have been fighting with chronic joint issues and musculoskeletal disorders that are unresponsive and they go everywhere and they can't get any resolve. So hopefully we can have some answers for them today.
Absolutely. I think that this is one of the conditions that come in really commonly to my clinic. And when you look, it's really important that you look into the whole history of the condition. You look at other concomitants, other factors that can affect this type of thing, because honestly, sometimes it's like the most minute detail that really leads you to the resolution of this and the improvement of the condition, honestly, in the end. So
I completely agree. A lot of times it's not the joint or the muscle.
Exactly.
Yeah.
So when we're looking at unresponsive joint pain or musculoskeletal pain, what would you kind of break down the common causes as far as like things that you look at when you're trying to evaluate what the cause is coming from?
Well, as you know, my clinic tends to focus on more metabolic, blood chemistry, and I'm looking for some inflammatory condition. That's what I'm looking at. Of course, I want to know their history. I'll do a physical exam. I know you do some very comprehensive physical exams. Finding is there trauma? Is there infections? These can cause joint issues. Is there mobility? Is the individual dealing with some nasty inflammatory condition that's contributing to the joint pain? So I guess in my world, I'm trying to cover all those bases. So I guess to illustrate it, probably like you, joint pain is more than just the joint.
Exactly. Yep. So I myself, when I look at it, I go, okay, is the joint fixated? Is it hypermobile? Is it immobile? Is there inflammatory conditions like you spoke about? Or is there other complications that aren't even related to that you maybe have glossed over or have been missed that are, can be pretty common in a lot of patients. And actually, we'll talk about that a little later in one of my cases. But to get started, you want to go through my case first or your case first?
Let's jump in your case.
All right. So my patient presented. It was a female, and she was in her late 70s, early 80s, and she came in and she had a lot of pain in her shoulders and her joints, like her proximal shoulders, unresponding to care. This patient had been to physical therapy. She had hired a personal trainer on the recommendation of her doctor. She had just tried everything, and it was completely unresponding to pretty much everyone. And she was frustrated, which is understandable because she was very committed. She did everything that was asked of her, and she just wasn't responding well. I knew through previous experience and exposure to this patient that she had other comorbidities to some certain other metabolic conditions, namely diabetes. And for some reason, when I was looking back through her paperwork, I was going through her pharmaceuticals that she was in, her prescription medications. And I noticed, even though her cholesterol was pretty much on point, that she had been put on a statin at some point by one of her other primaries. And when I actually asked her about, why she was taking a statin medication, she didn't really know. And we've talked about this in previous podcasts, but I was a little concerned because statin medications are the number one cause of polymyositis in the United States. And basically what polymyositis is, it just means diffuse inflamed muscles that are painful. So when we were looking through all this, and I'd done the history, I'd done the exam, nothing's like jumped out at me as like, oh, this is seriously wrong with this patient. It might be this. We decided to investigate a little bit further with blood work. And when we got the blood work back, there were certain markers within the blood work that had suggested that maybe she was having, that her muscle enzymes were high, her liver enzymes were high. So we actually ran additional tests to ensure that. And this patient actually was having diffuse muscle pain as a result from her statin medication. And that is something that she had seen a lot of people for, that maybe had just been lost because, normally you don't see that in a lot of people, but because of her age and her demographic and the fact that she was on a pretty high dose of statin, that was actually one of the largest causes for the pain that she was suffering in her shoulders, was actually that her muscles were actually inflamed as a result from the statin medication.
Wow. So you hit on something there that, a few things. One thing, you said that people, it was maybe missed because of, depending on the age, just assume that, creaky joints, if we want to call it that.
Sure.
So it was missed because it didn't fall into the category, the little window of age, gender, whatever, and it's conditioning. And then another thing that you hit on was, you said it was a major contributor. It wasn't the only piece, and maybe that's important. Can you kind of elaborate on that?
I guess as far as like the biggest thing for her was, like, does she have degeneration in her joints? Yeah. I mean, she's in her late 70s, early 80s. But the biggest thing for her was that she had all these other comorbidities that I felt like we needed to investigate. Could this be because she had diabetes? I mean, it's possible. I felt like that was investigating, and it was worth getting current labs in that certain circumstance. But then when I was looking back through the paperwork and I looked at all of the other prescriptions that she was on, I was like, one of the things that we see commonly with statin medications is, again, the diffuse fibrous muscle pain. And it was at that point where I was like, okay, I looked at her, I ran her labs again, and I looked at her cholesterols, and I was like, oh, they're really not that high. Why are you on this? She's like, I really don't know. So after that, I felt like it was worthwhile to investigate if she had elevated muscle enzymes, which you can run lab tests for.
What are those for the people listening?
It's the CPK enzymes. Yeah, so it's a muscle enzyme that happens when your muscles actually get broken down. And what can happen is there's other patterns within the blood work as well. So if your muscles are actually getting broken down, then there's going to be elevated protein in your blood, and that can actually alter the amount of blood urea nitrogen as well. And she actually had elevated levels of that. So I was a little bit concerned for that. So I actually ran the muscle enzyme test, and then I actually ran a liver enzyme test as well, because it can affect your liver. And both of those came back high. So it was at that point where I was like, okay, this could definitely be a comorbidity to the fact that she's having joint pain. That paired with the fact where she's in her 70s, 80s, she probably has a little bit of muscle or joint degeneration in there, and she probably has a little bit of muscular weakness in general. But I felt like that was something that had not been addressed up to that point in her care.
Mm-hmm. So
did that answer your question? I don't know.
Yeah, it kind of did in a roundabout way. So how fast was the response of reduction in musculoskeletal pain after the statin was slowed down or reduced or discontinued?
Yeah, so I sent her back to her primary care physician, and we talked about how her cholesterol was within range. It wasn't dramatically elevated. It was actually pretty well right in the middle of the range as far as lab ranges. So we talked about slowly titrating her off of that to make sure that that was something safe. And actually, after about 6 weeks of care, she noticed, I talked to her a couple of days ago, last Thursday, and the amount of pain that she is experiencing is dramatically decreased. I haven't seen lab tests yet because we were actually waiting because we have her on some other stuff that we're trying to improve with the diabetic side of it. But we're going to run lab tests again in about another 4 weeks. And we'll have to touch base back in that point to make sure that those enzymes are down. But I would imagine, based on the symptoms that she's experiencing, that she's improved dramatically. She no longer has the pain in her shoulders, and she actually feels like she's getting some strength back. So that's definitely a positive for her.
Oh, probably the statin isn't only affecting those muscles, it's affecting everything else.
All of them, right?
Shutting muscles down. Pain shuts muscles down. So then naturally there's a weakness. You did touch on one other thing, she's a diabetic. Mm-hmm. So maybe the question is, this is a tangent. This isn't part of really this podcast, but how much did the statin contribute to the diabetes?
Yeah, it could have, right? For sure. And we've actually talked about this in previous podcasts. So if you're listening to this and you have, questions on statins or pharmaceuticals or diabetes, we've ran through all these before in podcasts, but it definitely could have, right? Mm-hmm. And the interesting part was in this particular patient, I actually found the diabetes first. I was the one that found it. And it manifested itself as brain fog and joint pain and stuff like that too. But it actually was like a big inflammatory component that we were looking at in conjunction with the diabetes. Now, might her diabetes improve after we remove the statin medication? I mean, it's completely possible. But then again, it might also be possible because we put her on a diet, we put her on exercise regimen and all that stuff too. So I'm excited to see what her lab work turns out after 120 days of being on this stuff. But I think that it's safe to say that she's at least feeling better. She's sleeping better. She feels stronger, and she's not suffering from that chronic muscle ache like she was before. So that's definitely a positive.
Yeah, and some of that damage can turn in permanent if it's not identified correct.
Yes.
And the
Yes,
poison,
exactly.
we call it a poison,
exactly.
isn't for her. At least the poison was for her. It wasn't removed. So
exactly. Yeah, statins can cause a lot of stuff, a lot of long-term issues. And I'm not saying that they're necessarily terrible. I'm saying that you definitely need to monitor and make sure that things are being checked, because for her, they just assume because, she has this, or at some point, maybe she had that, that it's appropriate. And it might have been at that point, but after she'd used it for so long, and she'd addressed things like her diet and exercise, and it was no longer appropriate. So that's when you need to reevaluate, the lab work. You need to look at it and double check, because I mean, that could have been a really long-term consequence for her, is to have that for the rest of her life, or to keep having it for the remainder of her life, So definitely appropriate and important to double check. So
yeah, well, she's on her way now, right?
Yeah, and she's a great patient. She's doing everything she needs to do. She's very accountable. I love patients like her because, I meet with her every once in a while and we talk about how she's feeling. We talk about anything that she has concerns about, and then she goes on her way and she does everything she needs to do to get healthy. And I love patients like that. So
point them in the right direction, right?
Exactly.
Yeah.
Well, so what about your case?
Oh yeah, I had a case, and while we were talking, I know I was going to bring up a case, and I actually changed the case I was going to mention. So
on the fly, right on the
fly. There was this lady I worked with, and she was what was she, 39, 41, something like that. I can't remember the exact age, but it was right in that window. And she had thyroid disorder. She had many other issues that didn't seem like much of a problem, but she had this. What got her into the office? She had this terrible hip pain. She had to drive to the office. I believe it was an hour and a half, and she had to stop multiple times in an hour and a half because of her hip pain. Now, just to give you some context and the people listening of what this individual looked like, or their presentation, she looked like the amazing picture, the perfect picture of fitness. She was a CrossFitter. She was tennis. She was so many, Pilates. She was an instructor. I believe she was instructor as well. So she lived physical activity. She lived it. And of course, naturally, most people that I've worked with as patients that pursue physical activity, that's their passion, and this was also her career. If there's a musculoskeletal problem, they go to body work. So she went through the PT, she went through the massage therapy, she went through the chiropractic, she went through the acupuncture, she went through all sorts of different musculoskeletal and deep tissue work. It would last a little while, maybe a few days or a week, and it would tighten up again. Everything would tighten up. And it was going on for years and years and years. And, we looked at it, what I did, we did our exam and everything. There was a lot of mobility. She had range of motion, but there was pain with it, but she had range of motion, great posture, great core muscles. Everything seemed perfect, but what was going on? So when we ran a bunch of labs, we found all these bizarre inflammatory markers, things that were seen as a mild or a moderate or somewhat of a mild thyroid issue was kind of dismissed. And then other conditions that were slightly abnormal in the blood, it was dismissed. And all of these conditions, these dysfunctions in the blood, were great indicators of inflammatory conditions going on. She didn't have a diagnosis of rheumatoid arthritis or osteoarthritis or any arthritises, and it didn't show up in the labs. But she was suffering. It was affecting her, her career as being an instructor. So once we found all these disorders, metabolic concerns, that was the avenue. That was like the last avenue she was going into, is looking at what is behind the scenes or what's hiding in the blood. And we found many things. Once we started correcting that, and of course the formula was specific diet, specific lifestyle. We had to change her physical activity a little bit because there were some things aggravating her while she was going through therapy and recovering. But within a few months, she was able to turn it completely around. There were certain yoga poses she couldn't do. And again, this girl looked like the picture of fitness. And she could jump in the car and drive 12 hours, and there wasn't any tightness. So it was a great example of one of the things that causes of musculoskeletal disorders, or as we said, unresponsive joint pain. It was due to the metabolic disorders. It had nothing to do with physical conditioning, nothing to do with a lack of musculoskeletal or tissue therapies. It had everything to do with metabolic problems found in her blood. And the thyroid issue was actually one of them. It was quite a bit lower, and she had a really severe case of autoimmune Hashimoto's. So multiple inflammatory fires in her body that was kind of playing into her, specifically her hips, but it was starting to play into her neck and her hands. But within, I think it was 4 months, it was all turned around. Within 6 months, it was still improving. So she has her life back, but kind of a great example, like your case of what you saw from pharmaceutically induced, unresponsive joint and musculoskeletal disorders, and in the one of many cases, and I know you see many cases like this where there are metabolic conditions going on behind the scenes. I always say it's kind of like the other piece of musculoskeletal disorders is the metabolic problem.
Yeah, so, absolutely. Yeah.
So maybe just to recap some of the more abnormal, bizarre causes of musculoskeletal and joint pain. And, maybe out of these, maybe one of the more simple ones is postural and musculoskeletal imbalances. I know we were talking about when we started, so many people have joint pain and say, I don't know what the problem is, but maybe they're a driver or they're sitting at a desk like so many people for 8, 12, 15 hours. And it's not a relaxed day. It's tension, right? It's tension.
Yeah. I mean, how many truck drivers do you see? And they're like, oh, my low back and my neck hurts. Well, I mean, you drive 12 hours a day.
And vibration, not moving, So that's one thing. You talked about the complications of pharmaceuticals, and you're only bringing up one. Some pharmaceuticals, even some nutrients, too much of it can act as a poison in the body, and statins are high on that list.
Yes, absolutely.
I talk more about metabolic disorders, and they are more common than not. Very, very seldom is there just one of these things that are causing the problem.
And especially if it's unresponding, that's the biggest thing. Like if you go in and you're like, oh, this hurts, and they work on it and it gets better. Well, that's probably the cause, right?
That's right.
Or it's like, or if it's explainable, all of a sudden, oh, I did this and this is what happened as a result of that. And then they start to work on that and that improves. Well, then great. That's probably not a great candidate for what we're talking about right now. But what we're talking about is if you've had chronic, unresponding, musculoskeletal pain, whether it's in your neck or your back or your hips or your shoulders or your elbows, wherever it is, then you need to investigate other options as far as like looking deeper into that condition. Is it truly just a musculoskeletal issue, or is there some underlying component? Could you have an inflammatory arthropathy? Could you have arthritis from an inflammatory thing? That's what that means.
Or is it an inflammatory arthritis that is yet to be diagnosed, or is it not to the level of true rheumatoid arthritis and the labs come back as normal, but the person suffers and the joint pain is inflammatory? One day it's better, one day it's worse.
Yep. And the whole time the joint's being destroyed.
Yeah. Progressive destroying. So I guess a good example of knowing that there's something deeper that you have to go into other than just the musculoskeletal model is if you're doing all your therapies and you have to keep doing them.
Yep. And it helps a little bit, but it's still there.
Uh-huh.
It's like, I got better. It went from a 7 out of 10 to like maybe a 5 out of 10, but it's still there all the time. If that was truly the issue, then it would have responded a little bit better. So that's when it's time to start thinking, okay, is there something else going on?
Uh-huh.
And if that's the case, then blood work's relatively cheap. I mean, for the most part, it's really inexpensive. Now, the bang for your buck is really high. I
Yeah,
mean,
go
you
out,
and I say it all the time.
go out for dinner with your loved one, and
Yep, that's it.
there's your blood
One
panel.
dinner and you got your blood work paid for the most part. So I think that, again, if you're suffering from it and it's not improving, then look at other avenues. Find someone who's going to address other avenues or investigate other avenues that it might be, whether that's blood work, whether that is, hormones, whether it is pharmaceuticals. I mean, there can be brain-based stuff where, like, you have an issue with your vestibular system and all of a sudden your posture's messed up, or, you've injured a joint and then all of a sudden you have a chronic pain wind up like frozen shoulder or complex regional pain syndrome. This is really just illustrates and highlights the importance of finding someone who's going to look deeper than surface value. Mm-hmm. And that's only if it's unresponding. If you go, to whoever, your physical therapist, your chiropractor, your osteopath, whatever, and it responds, great. That's awesome. That's what you ideally would want, because then it eliminates a lot of the complications of that. But if it doesn't, or if it only gets better slightly, that's when you need to start looking a little bit deeper.
That's exactly right, because it's not, something has to change if you want it to change.
Exactly.
Yeah. Mm-hmm. So I guess that's a wrap for today, Dr. Colby.
Yeah, it was a pretty quick one, but I enjoy doing these cases. We should do a couple more of them in the future.
Yeah, we have a lot stacked, so we will.
So again, if this is your first time listening and you got value from this content, you can like and subscribe, turn on notifications so you get that notification when new content comes out. Share this information with your friends and loved ones. You can contact us at info@brainstormingwiththedocs.com. That's our email. Or you can get on our websites. Dr. Glenn's website is www.drgharrison.com. Or you can get on my website, which is www.northlakeschiropractic.com. And we'd be more than happy to try to point you in the right direction if we can, and answer any questions, or if we're capable of doing so, we'll do that. So until next time, my man.
That sounds good. I look forward to next week.
All right, buddy. Talk to you later.
Bye-bye.